than 11, they get nociceptive pain. They have basically nociceptive pain in between is unexplained. So by looking at this, basically, we can straight away diagnose the severe neuropathic pain, severe nociceptive pain. So you don't need to go through the patient fully again. When the patient feels this is self-reporting questionnaire, you see the questionnaire, you know what's going to happen with that patient. You treat them accordingly. So on the other side, you have the pain disabilities, but they are not doing with pain, and you have a depression. So you know actually the patient is suffering from depression with this pain syndrome. So by looking at this at a glance, basically, you know what sort of patient you are tackling and what sort of treatment you should be starting with. So management of pain. So medical management of pain is actually not very difficult. So for acute pains, you do a source control. You say appendicitis, you treat the appendicitis and you control pain, not just control pain and then you get disasters. So for acute pain, basically we have all these options: non-pharmacological NSAIDs, and tramadol, opioids, regional analgesics, various things. But for chronic pain, life is not that easy. Now, there are certain changes taking place sometimes. Maybe patient is being sensitized now, or already sensitized. So you have to treat for sensitization part of chronic pain in addition to the nociceptive components. So there are certain treatments that we can implement on these patients. For peripheral sensitization, sodium channel blockers. We have heard of carbamazepine, a sodium channel blocker, which is used to basically treat the peripheral sensitization. Calcium channel blockers, the alpha-2 beta ligands like gabapentin, pregabalin, again can be used for peripheral sensitization. For central sensitization, again, NMDA receptors, as I mentioned in that central sensitization part, NMDA receptors play a major role. So the drug you know is actually ketamine, NMDA receptor antagonist, but amantadine is another drug, antiviral drug, which was used some time ago for Parkinson's, can be used to mitigate effects of central sensitization. Same calcium channel blockers, pregabalin, gabapentin also work there in central sensitization. Other drugs are under experiment, so I'm going to describe. Again, restoration of descending inhibitory neural pathway is another important point in treating chronic pain. So 3 medications: tramadol, tricyclics, SNRI. So amitriptyline, duloxetine, venlafaxine, all these are prescribed in smaller doses, not in big doses like in depression, to potentiate this descending neural pathway. So, having said that, so how now acute pain, you cater the pain to the whatever you treat the patient to the severity. Say if the patient comes with some sort of small headache or an acute headache, you might give a paracetamol. But if a patient comes with the amputation of a limb, to straight away to give a opioid analgesic. It depends on the clinical scenario, experience and evidence. But for chronic pain, you can't do that. You have to gradually escalate to de-escalate treatment. So there are various ways of doing it. So this is one model of doing it. It's called analgesic ladder, which was described by WHO, but which was described for cancer pain patients, not for non-cancer, non-malignant chronic pain patients. So they describe it like you go by the ladder, by the clock, for the patient, depending on circumstances. But now for chronic pain, in 2012, our concept is mainly not just an analgesic ladder, but analgesic platform, which actually knows more than just analgesia by giving oral medications, so IV medications and some other interventions. So at the bottom of this platform, we have physiotherapy, non-pharmacological treatment, no medications, physiotherapy, mind-body integrations, chiroprathic treatment, acupuncture, all this stuff. And go out and step above, still no opioids, you can give NSAIDs, paracetamols, and combine with minor interventions like your trigger point injections, enthesiopathically treatment like injection of colpocephaly, botanical those things straight away without wasting time on other analysis or even going on opioids. There's no point being opioids for a patient with colpocephaly. So we are talking about more or less an analgesic platform in chronic pain management than a ladder. Having said that, the pain treatment itself is not the whole aim of chronic pain treatment. Because we may treat pain fully, but most of the time it's not the case. We can control pain, but we can't cure it. So our aim is actually controlling them to a point that they can be re-socialized, sending back to the society. Right? So to do that, actually we have to have a good pain relief, plus physical medicine, plus occupational and social interventions.